Good morning and welcome to Mount Sinai Cath Lab in what is our inaugural case of coronary function testing. This is our first live case for this specific application. And the goals today are really to help provide and spread education into this rapidly evolving field and area, and really review and discuss some of the procedural aspects of performing this in the cath lab. I really want to thank my guest moderator, Dr. Nat Smilowitz, who's coming up from NYU. In the room, we have a full team here. To my right is Dr. Pedro Moreno, my esteemed colleague, senior attending here at Mount Sinai and an interventionalist. I have Dr. Jamarjeet here. He is one of our interventional fellows. We have Ornab, our technician, Ashley, nurse, and Will, our nurse. All kind of our core team with our physiology testing here at Mount Sinai. So with that, I would like to start with presenting our case today. If you can show the case slide. Oh, great. Thank you. So just by way of just simple purposes, our target audience today is really designed for the interventional cardiologist, any clinical cardiologists, any healthcare professionals that are involved in the management of patients with angina and non-obstructive coronary artery disease. The prevalence of this disease is very high, and these patients are coming in very frequently to the office. But what we're finding is there's a lot of gaps in knowledge in identifying the appropriate patients that should be undergoing coronary invasive testing. And so what we want to do is review some of the procedural aspects of how to perform this comprehensive invasive test. And using the results of the coronary function testing, how do we then group patients into a specific endotype, which then allows us to target therapy, or at least initiate target therapy. Can you go to the next slide? So the learning objectives, like I mentioned, we're going to review the clinical evidence supporting the use of CFT. We're going to review all the procedural aspects and steps of performing it, including the anatomical, endothelial, and non-endothelial dependent mechanisms. And then we're going to apply the results in an up-to-date clinical trial, or apply the results of up-to-date clinical trials to help treat this patient population. And I've picked one case here, which I think is very illustrative. But before that, just an introduction. My name is Joseph Sweeney. I'm one of the faculty members here in the Interventional Cath Lab. I have Dr. Moreno to my right, and I have Dr. Smilowitz as the moderator. Myself and Dr. Smilowitz do have disclosures, which include we're paid consultants by Abbott, but that should not interfere with anything we're talking about today, other than Abbott does make the software and the wire that we will be using. Next slide. So the case we've chosen for today is a 52-year-old female. She has cardiac risk factors of being postmenopausal. She has nodular vasculitis, which was initially diagnosed with lesions on her legs, which was treated initially with Plaquenil. She has prior tobacco use, controlled hyperlipidemia, and a BMI of 20. She has a family history of a father with known coronary disease who underwent a coronary intervention, and a maternal grandfather that had a myocardial infarction in his 60s. She has laboratory data that shows she's not a diabetic. Her LDL is moderately well controlled at 90. Her CRP is 0.8, her creatinine is 0.8. Her case presentation was she presented to her referring cardiologist with a new onset of exertional symptoms, specifically angina, back in February of 2024, and this was why she was at a retreat and work. And she noted this as she was climbing up a hill. She developed substernal discomfort that radiated to her left arm and her back while climbing up an incline. If she got to the top of the hill and rest, it would resolve. It happened 2 or 3 times during that retreat, and she came back and didn't have it any further, except again once in March of 24, so just a few months ago. It prompted her to go to the emergency room, and in the emergency room at another hospital, she underwent an exercise treadmill stress test. The report of that stress test showed it was normal, negative, did not experience any angina on the treadmill, and she was sent home. She then developed recurrent symptoms, very typical as her initial presentation with chest discomfort on multiple episodes, and her cardiologist then sent her for a coronary CTA. The coronary CTA was done, and it showed just minimal non-obstructive coronary disease in the proximal LAD, which they quantitated as less than 25%, and a very small foci of calcified plaque with a total calcium score of 1. Even low score put her at a higher percentile given her age, and it marked her at 82nd percentile for her age, gender, and ethnicity. So with that, the decision was to proceed with now invasive coronary function testing to help further identify the cause of this exertional symptoms that she's having despite further, non-invasive testing. So before we get to the actual case, I want to highlight an article that I think is very appropriate for this case that was recently published. You can go to the next slide. Next. This was published in JACC in January of 2024, so almost a year ago, by Dr. Sinha in the United Kingdom. And very interestingly, the background to this trial, this study, was it's well known that exercise stress testing historically has been validated for detecting obstructive coronary disease. But it has a perceived high false positive rate, and we know that. The false positive, false negative rate is close to 50%. And I tell patients sometimes as good as a coin flip. And knowing that ischemia can occur in almost 1/3 of patients without obstructive coronary disease, the question that these authors asked were, are these false negative stress tests truly due to poor specificity, which we always claim after we see them, or instead, does it represent the limitations of using obstructive coronary disease as the reference standard to define myocardial ischemia? And the whole notion of myocardial ischemia has really evolved in 2024 to include both obstructive and non-obstructive disease. So the goal of the trial was really to do a systematic reevaluation of exercise stress testing against a more contemporary standard of assessing myocardial ischemia substrate, such as coronary microvascular dysfunction. Next slide. So the authors did this by enrolling, their trial design was very interesting. They screened roughly 300 patients, and those patients were presenting with chest pain. And the patients then underwent a coronary angiogram. And during the angiogram, they defined whether they had obstructive disease with assessing the FFR. If they had a positive FFR that was less than 0.8, they were excluded. But if the FFR was greater than 0.8, they then went on to the next step, which was looking at the endothelial dependent mechanism of coronary microvascular dysfunction. And they did this by doing an acetylcholine flow reserve. And they did this by measuring the coronary blood flow at rest, and then measuring after administering acetylcholine, and calculated a flow reserve based on that. And if the flow reserve was less than a certain value, I think 1.5, they then put them into the trial. And then after the flow reserve was done, then they proceeded with assessing the endothelial independent mechanism. By doing that, they administered adenosine, IV adenosine, and measured coronary flow by looking at Doppler flow, average Doppler velocity. And in doing so, they were able to calculate a CFR, which is basically the CFR with hyperemia over rest. And then at that finish, they stopped, and then they enrolled the patients in the trial for those patients that had abnormal coronary function testing. And then blinded, they underwent an exercise stress test. And the exercise stress test then determined patients that were ischemic versus non-ischemic. And roughly, the dynamics of those patients that were involved in the end, those patients that were ischemic were average about 62 years old, roughly 60% were female, and those patients that were non-ischemic were 59 years old and around 69% female. So a definite female preponderance. Next slide, please. And what the authors found that in looking at the ability of ischemia on a stress test, the diagnostic accuracy of determining if they have CMD was if they had an abnormal CFR was around 77%, the specificity around 77%. If they had an abnormal acetylcholine flow reserve, that specificity increased to 97%. Now, when you combine both an abnormal CFR and acetylcholine flow reserve, the specificity was 100%. So 32 of those ischemic patients had identifiable coronary microvascular dysfunction on that testing. And the predictors of those abnormal findings on the stress test were largely revolving around the acetylcholine FFR, or fractional flow reserve, which they defined as less than 1.5. But interestingly, a lower hemoglobin and also the peak heart rate that was seen during exercise stress testing. So I think if you go to the next slide, I have a couple comments on this trial. I thought this was a fascinating trial that opened up the whole idea of doing just exercise stress testing for these patients. However, the stress test was done after the physiology testing was done. So you obviously have a selection bias in this group. There's a very high prevalence of coronary microvascular dysfunction. The acetylcholine fractional reserve that they did, we don't typically do in the United States. At least we don't typically do it at this center or in the US, and it's really restricted to research studies. And the operators also used average peak velocity, and this is a Doppler flow wire. And what we've done is moved away from that, moving more towards thermodilutional flow. And that's done what we'll be doing today with a Cora flow wire. And the aspects of comparing Doppler flow velocity versus thermodilutional is unknown. What the authors did not do is they did not test the patient specifically for epicardial vasospastic endotypes. But what they did do is this fractional reserve of acetylcholine. And my thought is, and Nat, I'll be curious to see what your thoughts is, that what they're probably looking at is microvascular spasm with acetylcholine, because they didn't identify any vasospasm, epicardial vasospasm. So what this trial did is really brought a new role for exercise stress testing. And the thought was, the authors said, if you have a patient that you suspect ANOCA, do a coronary CTA, rule out obstructive disease, and then the second line, perhaps go to a stress test. If it's positive, you implicate coronary microvascular dysfunction as a cause, and could you just treat it? I have some reservations of doing that, which we can talk about, but that's really what the authors were implying. Next slide. So in summary, the ischemia detected on an exercise stress test had 100% specificity to detect CMD and ANOCA. The patients with an EST ischemia had lower acetylcholine flow reserve. The endothelial dependent CMD was the strongest predictor, that's the acetylcholine, on the exercise stress test. And this actually may be a better indicator of microvascular dysfunction over the endothelial independent testing, which is the adenosine. And I think that's why it's so important. One of the messages is we have to test these patients. And performing comprehensive testing with acetylcholine is really critical, and not just stopping after just doing a endothelial independent mechanism. So I think in summary, what this trial shows is it gives a mechanism of ischemia rather than just what we tell patients of having non-specific chest pain or false positive stress test, which is in many patients very reassuring. So with that, Nat, I don't know if you have any familiarity with the trial or any comments in your practice, how you apply this.
Yeah, first of all, thanks so much for having me. It's really a pleasure to be here, and I'm so glad you highlighted this study. You know, I think this is paradigm changing. I think that the idea that you have a positive stress test and you have non-obstructive coronary arteries, people historically would just reassure patients and say, this is a false positive stress, you're fine. And fundamentally, that's not really true. I thought one of the most important stats from the paper was that in patients who had a negative stress test, much like the patient you presented today, 66% of those patients had a diagnosis of microvascular disease, while 100% of the people who had a positive stress test had microvascular dysfunction. So really, even with a negative stress test, it doesn't exclude the idea that you have an ischemic syndrome going on, and it doesn't even necessarily obviate the need for coronary function testing, even without a positive stress test. So, but that said, if you do have an abnormal stress test and you have open arteries, there's certainly a high probability that something is going on. And as far as the microvascular testing with adenosine versus acetylcholine measures, I think they're probably complementary, and I think that we'll likely be moving towards, and I think we already have moved towards, comprehensive functional testing with both acetylcholine and adenosine. How that's done in 10 years, who knows how that will compare to how we do it today. But I think thinking of the diagnoses and starting your testing is really important.
Great. So with that, I think what we'll do is we'll move to our case.
So I see you have a guide up already.
Yep. So what we did is we started with a basic angiogram. And you see right up front, this looks like a pretty normal angiogram, taking our different views, ariocaudal. One thing, she's got some fairly tortuous vessels, which is interesting, and how that may come into play with what we find. Her LAD is a beautifully straight vessel with the distal vessel being tortuous, but a large caliber vessel, and no clear obstructive coronary disease angiographically.
Yeah, beautiful angiogram.
Yeah, her LV function is completely normal. And she has a right dominant RCA, which is completely normal as well and clean. So I think the CAT scan was correct.
That's right. The CCTA doesn't lie when there's not a lot of calcium.
Yeah, exactly.
Now,
so,
I see you went femoral here.
We did. What I typically do is I'm trying to do most of my cases radial. This patient has a very short stature. And my concern is that the short stature and the size of her wrist were so small that we would induce some vasospasm. And in doing so, I'd have to probably give some vasodilators, which I didn't want to do.
Right.
So I don't know, are you doing mainly radial, or how are you?
It's a good question. I think of this as a discussion with the patient, and so I'll offer them radial or femoral, and if patients have a strong preference, I'll go with their preference. But I do warn patients that because we don't give vasodilators, so that we don't get falsely negative spasm testing, I will have a low threshold to convert to femoral if there's radial spasm. And so for that reason, many of the patients actually opt for femoral access up front, with the concept that it's one and done. You get femoral access and you get the case done that way. Right. Whereas there's a possibility of conversion from radial to femoral in those patients who may develop radial spasm. That said, I think that for young men, I usually can get away with radial, no problem. But for women who are shorter stature, just like your patient, this may be the best option.
And when you do go radial, do you give a radial cocktail?
I don't. I just flush it with saline and get the catheters up. Yep.
That's pretty much how I do it. And if I do have to do it, I tend to just wait. I give it about 10 minutes, and just to make sure that all those vasodilators have worn off. Okay, so we are fully engaged. Here is our guide picture. We have good guide engagement. And so I'm going to start with the acetylcholine endothelial dependent assessment. Now, one of the things that's so crucial about doing these studies is you have to have a very good relationship with a pharmacy. And we do have that here, so much so that we depend on them to actually mix for us. They're able to get us drug within 30 minutes, which is great. So sometimes we can do patients ad hoc, but sometimes we can't, depending on the hour. So mixing in the cath lab is preferable. I'm not sure. What do you do in your practice?
So we actually mix in the cath lab, but because of, and maybe we can talk about this a little bit, but most of our cases are planned and not ad hoc. And the reason for that is that many of the patients are on drugs that we might want to hold prior to testing, so that, again, we don't get falsely negative acetylcholine spasm testing. What's your practice for withholding meds?
I usually hold at least long-acting nitrates, calcium channel blockers, at least 48 hours. If I can't, 24 hours is good enough. Beta blockers, I'm hit or miss on. I know some of us in the network do hold beta blockers, but I typically don't.
Yeah, I'll hold beta blockers, particularly if they are non-selective beta blockers.
Right.
I try to, but in my practice, I don't hold ACEs or ARBs. I don't want them to be wildly hypertensive during the case. Have you continued those antihypertensives?
I have.
Yeah.
The only one I will stop is if they're on an alpha, such as carvedilol or labetalol,
Right.
to that effect. But otherwise, I will proceed.
Yeah, and so for that reason, at least in our practice, I think that it makes sense to do these cases in a scheduled way so that you can hold all the necessary meds. And so ad hoc testing is a little bit less common.
Yeah, exactly. So what I've done now is I've loaded. Ashley handed me a 20 microgram dose, so we call this the endothelial dose. And when we give this dose, anything less than the vessel staying the same in diameter or dilating would be consistent with endothelial dysfunction. So this is a 20 microgram dose. So what I do is, if you want to show the manifold, is I load the syringe onto I'm on a manifold here, onto our 3-way stopcock, and then I park the dose into the tubing. And the tubing is roughly about 4 cc's, 4 to 5 cc's. And I have a 20 microgram dose in a 3 cc normal saline. And then what I do is I start a timer, and I know I'm going to have to displace at least 3 cc's into the guide or into the coronary. So what I do is I take a 10 cc saline flush, and I tell my team to start the timer. Get a baseline EKG, please. And I'm running a 12 lead EKG at the same time. I don't know if you're able to see that, Nat.
Yep.
We can't see the 12 lead ECG.
Right now.
Okay.
It's coming now, yeah.
There we go.
Okay, so the 12 lead EKG is extremely important because the main side effects of acetylcholine that we see is bradycardia and pauses, and sometimes block. And a lot of that is dependent on the rate that you're infusing the med. So what I'm doing is I started the timer, and ideally I like to deliver this over a minute. So I'm slowly infusing this, watching her heart rate.
Now, what do you do if you see heart block?
I stop. And 9 times out of 10, it resolves and it comes back. And then I basically just go very slow, much slower. My infusion rate is a little bit slower.
And so your total planned infusion time for this starting endothelial dose is
about a minute.
About a minute.
Yeah, and if it needs to get longer, I'll go longer. The half-life of acetylcholine is short, but the stability testing, we haven't done stability testing on ours, but the literature supports around 4 hours. Now, I know some of us across the country that are doing this say they can do it up to a day later. What have you found in your practice?
So we will generally use it within 24 hours, well, within that same day. We'll mix it and we'll use it for the day. But there have been centers that have done stability testing locally, and this may not apply to all centers, but that it's fridge stable for a week. So, we may be a bit conservative on the shelf life and the half life, but I think certainly if you use it within a day and within 4 hours, you're definitely safe.
Yep. Okay, so the drug is in, and what I do is I have a practice. I inserted about 5 cc's of saline, so my guide is cleared of acetylcholine, and then what I do is I suck back, because what I don't want to do is if there is any residual acetylcholine in that guide, what I don't want to do is bolus it, okay? So I have a practice of sucking back and wasting it. Right? There's very few in there, but if you do have residual and you bolus it, that's sometimes when you can run into trouble. So we now put up a magnet that tells us what our dose is, and then we're now a minute. Go ahead and check an EKG. And we're assessing the patient for symptoms of chest pain. We're assessing the patient for any EKG changes, which she's not having, and then we'll assess the patient for spasm.
All right, so far so good.
So far so good. So this is pretty pretty unremarkable first dose.
Now, what's your observation, Ben, when after you get that first dose and you don't have a change? What's your next dose, and what do you think the likelihood is that the next dose is going to be abnormal?
Yeah, great question. So my next dose is I go to 100. This is the vasospastic dose. So what we do is we exchange it here. This is 100 mics in 3 cc's. What I was doing when I first started is I would do 20, and then I would go up to 50, and then 100. I do know, the literature on there on gender and doses that we should go to suggests in females really 100 is the max. In males we can go up to 200, which we have done. But in her, I'm probably going to stop at 100.
Yeah, that makes sense. In our practice, we initially did 200 in everyone, and the literature, just as you suggested, just as you indicated, suggests that you don't get any additional diagnostic yield for the higher dose, but you can get more side effects. So
absolutely,
I think that makes a lot of sense to stop at 100.
Absolutely.
So Joe, tell us a bit the diagnosis of coronary spasm by acetylcholine versus endothelial dysfunction, angiographically speaking.
So what's interesting, let me just infuse this. You can get an EKG. So now we are on a 100 microgram dose, and we're going to go ahead and start infusing now. So it's parked in my guide.
And what's the duration of administration for this dose?
So this is going to be, again, over a minute.
So the key here is really slow infusion so that you don't get heart block.
And I just watch. If I start braiding, I slow down. And it seems to resolve pretty quickly.
This is a good type of case to have an audible QRS. So you really can use all your senses to.
So Dr. Moreno's question is a great one, and it's one that I wanted to ask you, Nat. The way we're diagnosing coronary epicardial vasospasm with acetylcholine is visual inspection. We were doing QCA in the beginning. All the literature suggests you need at least a 90% narrowing, as well as EKG changes and symptoms. I don't know about you, but in my practice, I rarely see all three.
Yeah, I agree with you. And I think that when we think of the definition of coronary spasm, it's a very strict definition and maybe for good reason. I think that the authors of this definition were thinking about for the purposes of research to have a clean sample where there's definitive coronary spasm, but you see a lot of patients with an 80% stenosis with chest pain and no ECG changes, or ECG changes and a 90% stenosis but no chest pain. It's all over the map. I agree with you. You get 2 out of 3 all the time. And I think you have to take this and you have to use your clinical intuition to recognize when there's likely clinically significant coronary spasm that may not meet the strict Covatus definition that requires a 90% stenosis, ischemic ECG changes, and reproduction of symptoms. I think the symptoms are particularly challenging because you've given this patient sedation. I'm assuming this patient got fentanyl and Versed?
Correct, and that's one of the aspects I was going to say, that the patient is lying flat on a bed under an immense amount of sedation. So whether the symptoms are going to be there or not. I also feel, and I don't know how you feel about this, is that if I push to 200, let's take this picture. Go ahead and check your EKG.
Yeah.
So I did that over a minute and 20 seconds.
Yeah.
So this is now 100 mics. One very important learning, this nitroglycerin always has to be on the table when you're doing these studies.
Yeah.
Beautiful.
Yeah. So essentially negative.
Our
guide popped out at the end there.
Yeah, I think your point about the nitroglycerin is so critical. So if you're doing if you're doing this testing, the nitroglycerin and the acetylcholine have to be in designated spots on the table.
Exactly.
The nitroglycerin has to be available at all times, and the acetylcholine, when you're done with testing, it's so critical to empty those syringes so you don't accidentally use that as a flush later in the case.
Now, what I'll also do is I'll take another view. I'll take another view after the 100. She's very stable right now. I have time just to make sure I'm not missing anything in the circ or other vessels. So that's after 100. So pretty normal study.
Yeah, I'll say.
And now what I'll do, even though I don't see anything, I will reverse. So I'll give up to 100, 200 of nitro.
Now, what's the purpose of giving nitroglycerin in this scenario?
Well, I think the one is, one thing that I think we have to get better at diagnosing, and myself, is microvascular spasm. Could she have a degree of microvascular spasm here? That if she does, then I'll reverse it. So when I move on to do my next testing, everything will be, in order.
That's right. That makes a lot of sense, right? All of the physiology studies were done with nitroglycerin preceding the testing. Correct. So you're going to have to give it anyway. This is as good a time as any to do it.
Exactly.
Yeah,
now,
just a comment about this testing. We started to do this about probably 18 months ago, and in patients that are really symptomatic, the acetylcholine coronary spasm testing is fundamental. To start the program, sometimes it's difficult because already mentioned the issues with pharmacy and how to mix the medication. But I will encourage everybody to be very obsessive in doing the spasm, because that's the group of patients that will benefit more for aggressive therapy and will be very, very happy after. If I think about interventional cardiology, the benefit for a patient after the ACS and the severe AS symptomatic class 4 angina, I will put this as the next category in helping patients. So be aggressive in your protocol and try to do it from the beginning, your acetylcholine, because you will find a lot of spasm, very tight, sometimes total occlusions, very simple to treat, and very great benefit for the patient. Just a comment, yeah.
That's such an insightful comment. I couldn't agree more.
Yeah, in fact, when we first started, I was worried I was overdiagnosing spasm. Everyone that was coming in was having spasm, and I thought, and what am I doing wrong here? But I think this is, a select population. These are patients that have ANOCA. And, I think in the prevalence of vasospasm historically amongst ANOCA is around 40%, if I'm correct. So it is a very prevalent disease that only until now have we had the standardization of protocol to be able to say, let's test for it.
Yeah, it's great. In the Cormica study that was published in 2018, which was really a foundational trial in this space that showed that with this comprehensive testing, patients feel better and you have much greater diagnostic certainty. Sure. The vast majority of patients had a diagnosis. So less than 15% of the patients who underwent testing had a non-cardiac cause of their chest pain at the end of the day. So, the complete protocol is so important with acetylcholine to make a diagnosis.
Okay, so now we shift. Now all the acetylcholine is gone, and now we're going to go towards the non-endothelial dependent mechanism of ANOCA, which is microvascular dysfunction. Although what I learned in that paper is microvascular dysfunction can have both an endothelial and non-endothelial mechanism, but I think right now we'll make it simple. We are now going to test for microvascular dysfunction of the microvasculature by inducing hyperemia. So to do this, we're using a CoraFlow wire. This is the Abbott wire that has a unique property of having thermosistors in a spot where it's able to measure the flow of saline that we inject down the artery. The wire comes in the typical FFR wire type of manifold or packaging. It's important to zero the system first and then hook up the Bluetooth and obviously keeping it in saline at the same time.
I was going to say the principle of this thermodilution approach is very similar to the approach to measuring cardiac output with a Swan.
Exactly.
So it's the same principle as just miniaturizing the coronaries.
That's exactly right. And the simple Ohm's law, I try to tell our fellows sometimes.
Mm-hmm. So now, where are you going to put the wire, and what's your sort of strategy here as far as where to measure?
Great question. So we typically only do the LAD unless there is a targeted need to do a different vessel, such as a myocardial stress test that then shows no obstructive disease and it's showing RCA ischemia. Sometimes we will do the RCA in that scenario, but by and large, we're typically only doing the LAD. And I think that's pretty standard across most of us that are doing this.
Yeah, I mean, I think that's where most of the data are. We have the most robust evidence for LAD testing. So I think I think that's the practice at most centers.
Okay, so it's very important to zero this wire, and now we're going to equalize. So the wire introducer is out, the guide is out, and Ornob is going to go ahead and equalize the wire, and he's giving me the thumbs up. Now, I put this wire down about, the teaching is generally at least 6 centimeters or 60 millimeters. And usually I tell the fellows that's typically where the bend is on the areocaudal view.
Yeah, I think that the 6 centimeters, some people use 2/3 of the LAD.
Yeah.
I do think that it's important that, and you probably, I'm sure you do this too, is that you want to avoid pleating because you don't want to introduce any epicardial narrowing into a vessel that's otherwise healthy. So if it's a really tortuous vessel, sometimes you have to take that into account when you're deciding where to position your wire. Exactly,
and that's what I'm doing here. So you see all that tortuosity distal. It's a great point, Nat. So the thermoresistor is in the proximal part of the black marker that's going to measure the temperature. So I think I'm at least 2/3 of the way down the vessel there, or at least before the tortuosity. Now, I cine this because one of the things that we run into is wire drift, which in physical wire drift, not the physiological wire drift, but when the wire drifts down or up, you can run into problems because obviously your duration of time, transit time, is going to be longer. So right now, what we're going to do is, you see the screen up here. This is the CoreFlow platform. It gives us a first reading of where our wire is. We get an RFR, okay? And this is the resting full cycle ratio, which is kind of the poor man's version of an FFR, a non-hyperemic version. And the RFR is measuring 0.93. So this is north of 0.89. So this is a non-obstructive LAD, which we knew, but it's nice to have that information. And what I do now is I'm going to inject 3 cc's into my tubing, and that is going to displace saline that's in the guide into the coronary, and it's going to measure the temperature flow. So the first one is always a test, and it has to be a very rapid injection.
I get asked this question all the time. Does it matter what temperature the saline bag is?
I don't think it does. Generally, they want to say room temperature, but I think it's all relative.
Yeah, I agree. I think that as long as it's the same temperature throughout the case, there's no problem. And using a manifold here is really helpful because it prevents any air bubbles from getting into the system when you're giving your injections.
Exactly. So there's our first test.
Very key is the position of the guide.
Yep.
So if the guide is out, your testing is not going to be good. So be sure your guide is properly engaged. Yeah.
So I wait till the temperature gets back down to 0. You see our first curve there, 1.34 seconds. I repeat it.
This is important. So 1.34 seconds, you're going to see it after adenosine, how that changed.
So Dr. Sweeney, what is a normal resting transit time?
Great question. I think it depends on the length of the vessel, the coronary flow in the vessel. I'm seeing on average anywhere 1.2, 1.1. I don't know that there's an actual value for that.
Yeah, I think it's patient specific, but does this fall sort of within the realm of what you would have expected for this vessel?
Yeah, it is. It's all relative. Now I'm going to repeat the 1.5. I like to get these within 0.1 of each other. So actually we could repeat the 1.4, 1.3 if that's okay. So the nice thing with the software, you just delete the one you don't want.
So when I'm looking at these numbers, I'm often looking at both the curves on the lower part of the screen, but also the curves on that moving axis, because that can give you an indication that there's something wrong with your guide position, which is so critical. Maybe you can discuss more about this.
And I think that's a great point, Nat, is our learning curve was what we call injection hygiene. It is so important that your curves are at least within the same zip code, and kind of not directly on top of each other, but you see these curves are kind of in the same area. So I'm going to repeat the 1.2 one more time.
That's the guide or not?
No, I think we're okay. You can take that one out.
Now I see it's a very brisk injection.
Yeah. It has to be a brisk injection. You don't want to do it slowly.
And so when the wire is detecting the change in temperature,
yeah,
the computer is then calculating the mean transit time, which is the time it takes from the cold saline bolus to go from the proximal portion of the wire to the distal tip of the wire, or at least the black part of the wire.
That's exactly right. Okay, I think we're good. 1.45, 1.46, 1.51. I'm pretty happy with that.
I love it.
Okay, so now we are going to induce hyperemia. We're going to open up those microvascular vessels. Go ahead, Ashley, you can start. We typically do this at a dose of 140, and we're going to look for hyperemia. So we're going to see a separation in your PDPA. You're going to see an increase in heart rate, a drop in the blood pressure overall, and symptoms. Those are the things that we typically look for. And then once we hit hyperemia, we then repeat our flows. And then it's a simple equation. The CFR is going to be the hyperemic flows over the resting flow. And in a normal vessel, you should be able to augment flow 2.5 times. And that's a simple definition of coronary flow reserve. The index of microvascular resistance, which is what this calculates, is a product of the hyperemic flow time times the PD. And that gives a number that we typically say anything more than 25, 28 is consistent with high microvascular resistance and dysfunction, meaning those vessels are not opening up to hyperemia. So we're getting a little tachycardic, which is good. We're at a minute 10, usually takes about a minute 20. She's tolerating it well.
So just as we're achieving hyperemia, I want to remind anyone watching online to please put comments and questions into the chat. We're happy to address those. So feel free to engage and to post any questions you have.
Please ask questions. Dr. Smilowitz is the co-director of the Microvascular Network. He's a wonderful resource. I'm going to ask him questions.
I have few too.
Yeah.
So how long do you wait to achieve hyperemia?
I at least, once I see the signs, I'll do it right away. I don't have to wait a specific time. If I don't see hyperemia, then I'll wait 2 minutes. Sometimes we do a higher dose, but she's clearly hyperemic here.
Yeah.
Our temperature's back to 0.
So I find that when I'm measuring the hyperemic transit times, I get much more consistent and tight curves than with the baseline flows.
I agree. And we're shifting. So our hyperemic curves are in orange, so we're shifting left here. She is augmenting flow very significantly. I mean, her flows now are 0.3 seconds. So our 0 back to 0, third, final one. And so you see that nice knife dagger injection there. Mm-hmm. Those are beautiful flows. I'm happy with those curves. And we're getting an IMR of 14 and a CFR of 5.7, a resistive reserve of 7.4. This is all telling me she has normal microvascular function.
Yeah, and you've really nicely demonstrated hyperemia with that rapid increase in the transit times.
So we kind of stop.
Adenosine. Yeah. And now what we like to do is an internal control, just doing a wire pullback to make sure we're not having any drift. So I'll slowly pull back here. But she's tolerating this very well.
You want to see him before or not?
No. And we're looking at us getting close to 1.
It's perfect. Yeah. Yeah, we generally like to
short.
see 0.03, 0.02 drift.
And that's within acceptability.
Yeah, and I think that, you have such compelling and convincingly normal IMR and normal coronary flow reserve here that even a little drift is not going to change your diagnosis.
We have air.
Yeah.
Let me just get it out.
So, Dr. Sweeney, what do you make of this microvascular testing in light of her symptoms?
So that's a great question, Nat. And I think her symptoms are, I'm going to tell her at the end of this case that this is probably non-cardiac.
Yeah.
Now, the only thing we didn't do, and what I typically do is looking at some of the other endotypes, is a bridge.
Mm-hmm.
And the notion of a bridge, what I do is I look for any angiographic evidence of a bridge. If I see it, I'm then going to image it. I prefer to do IVUS because I can see the dynamic compression. And if there is confirmation on the IVUS of a bridge, then what we want to do is physiologic testing of that bridge, looking at the diastolic FFR. And that's a whole nother live case we could do in that. I think I want to keep things as simple as possible.
For the audience, there is a documentation of testing these with dobutamine, and here in the cath lab, and we have done it, but it correlates with proving ischemia non-invasively, but really doesn't add to the treatment of the patient. What about that point for discussion? Yeah, doing dobutamine in the cath lab for the FFR.
Yeah, it's a great point. I think certainly if you have a suspicion of a bridge angiographically, it makes sense to go down that road. In somebody without visual evidence of a bridge, I think it's unlikely that you're going to find a positive bridge, but certainly that is always a possibility. It's another live case for sure.
Yeah, and Nat, Olga presented an amazing case at one of our microvascular meetings of a bridge that she found and taught me so much on how to assess those, and actually doing non-hyperemic with IFR or RFR, not having to use dobutamine, but measuring the bridge index and just a great talk. So maybe
bridge
that
length,
would be
bridge depth.
Exactly,
there's a lot there.
Exactly, but I don't see any angiographic evidence of a bridge here, so I don't think imaging her is going to provide any further information.
I don't either. Well, there were some questions in the chat. I'm just going to pose those to you guys. So the first question is, what are the absolute contraindications to this kind of testing? And I guess in that vein, maybe who should get testing as well?
Wow, that's a great question. So the absolute contraindication obviously is what we usually follow. With adenosine, you want to be careful in somebody with inhaler-dependent bronchospasm. Now, that being said, our patient here did have a history of exercise-induced spasm or bronchospasm, but she was not taking inhalers. So I think you want to be careful. You want to weigh the risk and benefits of that decision. And with acetylcholine, I haven't found an indication or a contraindication, and I'd be curious to what yours is as well.
So I agree with you about bronchospasm, although I have a very high threshold to not do a case for that. I mean, it would have to be, history of intubation for asthma or ICU admissions for asthma.
Correct.
For acetylcholine, I guess the only sort of relative contraindication is bradycardia. Yeah. But even then, if need be, and they do this quite often in Japan, they'll actually put up a transvenous pacing wire to support the heart rate as you're doing the acetylcholine testing. I've not done that really ever, but it is something that you could consider doing in somebody who's very bradycardic at baseline who has an indication for testing.
Yeah, and sometimes we do put pacer pads on just in case, and the perfect patient is a patient with a pacemaker actually. And one other question that came up to me is I have some hesitation of doing acetylcholine in the RCA. I've done it with good outcomes. I use a lower dose of acetylcholine. I max out at 50, but that's really where you can run into a lot of the bradyarrhythmias and dangerous arrhythmias. And so one of the things that I encountered when I first started is, what do I do with a left dominant system? And in the beginning, I was hesitant to do actually provocation testing, but I've done a few now and they go fine. You just go slow and you watch for block. And if you see it, you stop or slow down.
Yeah, that's really helpful. I've had the same experience.
Yeah.
Regarding the second question, it is a group of patients that I think we shouldn't be doing, and are the patient with extensive previously documented CAD with multiple stents. And some people use it, I have seen it, but we know that in diffuse coronary artery disease, the flow is altered, and your CFR is going to be altered. So what about that? I don't do it, but I've seen it, people doing it. Yeah.
Yeah, I will generally not do spasm testing or coronary microvascular testing in patients who have obstructive coronary disease. But after revascularization, when they have functionally open arteries, once the stents are in, and if they still have residual symptoms, we know that 33% of people after PCI still have angina. So I will test those patients.
Okay.
So, but your comment is, I have done it on stents, and I've had a case where the vessel actually spasms right after the stent, and the outcomes were fine. But I thought retrospectively, my goodness, that could dissect the vessel very easily. You're basically closing down on the distal edge of the stent, and it could tear it. I think that's theoretical. I haven't seen cases of that, but the whole idea, should we be doing microvascular testing with adenosine and dropping the wire down in patients with obstructive disease, or at least obstructive disease that was fixed? I do think there's value in that, actually, of testing patients that have residual or persistent angina even after revascularization.
Yeah.
So just the vasospasm you want to be careful
I guess
of.
the key is, if your RFR is abnormal, you should stop and don't think that you have to stent more, because with diffuse disease,
Correct.
you have FFRs that are actually really low sometimes.
Correct.
Yeah, good point. Now, switching gears, we have spoke ANOCA. What about MINOCA? I mean, with ANOCA, you're done here. But with MINOCA, we used to do, MRIs, and we also do intravascular imaging. What about this particular testing for patients with MINOCA? Yeah.
It's a great question. So, my feeling about MINOCA is that the MRI and the intravascular imaging is really the sweet spot as far as testing, and that acetylcholine testing is probably also very helpful, because I think a lot of these patients do have spasm, although I'm a little hesitant to do spasm testing in the setting of MI. I know there have been studies that have shown it's safe, but it's not part of my routine practice. I think the CMD testing is of uncertain value, because I don't know whether the microcirculation is impaired as a primary cause of MI or as a secondary cause of a thrombotic syndrome there you have plugging of the microcirculation from some other cause. And then I think that could be a red herring, actually. So I don't do microvascular testing in the setting of MINOCA, but I will do spasm testing on occasion, particularly people who have recurrent MIs with open arteries and low-level troponins.
Yeah.
A very interesting dichotomy here for the patients that we should not do upfront when we start in a program. MINOCA is another ball game. Yeah.
Yep. Yeah.
It's very unknown. Nat, are there any other questions? We're getting close to the end of the hour.
Well, I think when you're framing the results to patients, how do you describe this set of diagnostic tests, and sort of what's your approach to the conversation to the patient?
I think the way I talk to patients after this is I have a long process of sitting down with the patient before this, and I describe exactly what I'm doing, the risks associated with it, but more importantly, what the findings are going to tell us. And I think having that discussion before is very, very helpful, because what I found is most patients understand this. I give the example of a tree. With the leaves and the branches and the epicardial vessels and the microvascular vessels being the leaves, and they get it. And so when I tell them that all these testing that we did is not pointing to a problem with your heart, that this truly is non-cardiac chest pain. And I think the power of that is so high to give a patient a true diagnosis of non-cardiac chest pain. And even more powerful is when you can take medications away.
I think that's such an insightful point.
Yeah.
She's 52, and you're not going to commit her to a lifetime of anti-anginal therapies that are not going to work.
Correct.
Yeah, one point about that is in the patients that really have angina, they're going to be pleased that you're going to do this. Up front, they want to have an answer. In the patients, then the chest pain is not that clear. There's some, then you have to go over all this discussion. But you will identify the true positives in the office because they really want something. They have gone to another physician, they send them to psychiatry, all of that, and they are very pleased after.
Yep.
Yeah.
Completely agree.
Yeah, I found there's a lot of patients really truly appreciate this kind of testing, particularly after they've been bounced around and falsely reassured or dismissed, quite honestly.
Yeah.
And so to have somebody take them seriously, do all the testing, and get to a diagnosis or diagnosis of non-cardiac chest pain, which is equally powerful, is so critical.
Now, a question for the interventionalists in the group. What about RVUs here or reimbursement?
Oh, Dr. Moreno.
Yeah.
So, billing is the good news is there are billing codes for testing provocation. There are billing codes for testing microvascular function, although it's not specific for microvascular function. It's actually billing for an FFR now. Although I know, Nat, there's been some work on that on the Hill. Have we had any updates on that as far as you know?
I'm not aware. We have diagnosis codes, but I'm not aware of any changes in reimbursement.
CPT codes, yeah.
Yeah.
But it is reimbursable, doing the testing. And so, and like I said, these patients, will send her home in 2 hours. No need to stay overnight, very ambulatory. So I think that's it. So I think if there's no other questions online, we'll wrap it up here. I want to thank everybody in the room for being here today, this early morning, and Dr. Moreno, my colleague and mentor, and Nat, wonderful to have you, and thank you so much for all the work you're doing, and hopefully we'll see you again.
Thanks so much. It's a pleasure to be here.
Okay. Goodbye, everyone.